Okay, let's start with the clinical manifestations of renal diseases. First, two characteristic manifestations associated with mostly glomerular diseases are nephritic and nephrotic syndrome. Let's start with the nephrotic syndrome. Nephrotic syndrome is a four symptomatic characteristic which is necessary for us to conclude that this is a nephrotic syndrome. So those four characteristics have to be present. First and most important is proteinuria, which is always more than 3.5 grams in 24-hour urine sample. I like to remember nephrotic syndrome as nephrotic and oncotic, right? Oncotic pressure is connected with the proteins in the blood. So nephrotic and oncotic have like a similar sound. So that's how I want to remember, as the proteinuria is most evident symptom here. So nephrotic syndrome, there's always more 3.5 grams of protein in urine or more. We have hypoalbuminemia, which means a decreased number of albumin in the blood due to proteinuria, as you know. So albumin is getting lost in urine. So there's generalized edema due to loss of proteins, and we have hyperlipidemia and lipiduria. So proteins, albumin as well, and other proteins are also function as regulators of lipid metabolism and transport. And if there's a depletion of those proteins, there going to be a compensatory increase in synthesis of lipids in the liver, which causes hyperlipidemia and consequently loss of a lot of lipids in the urine. Now, the second syndrome is nephritic syndrome. So in this case, the major symptom I would like to remember for is a hematuria. This is the presence of blood in the urine. It can be gross and microscopic. Microscopic is when the patient cannot see blood in the urine. Now, it has four characteristics as well. If any of those characteristics are missing, nephritic syndrome is not present. So all four characteristics have to be present in order for us to conclude it's nephritic. First, there's a subnephrotic proteinuria. This is always less than 3.5 grams in 24-hour urine sample. We have hematuria, as I said, it can be gross or microscopic. Then we have hypertension and azotemia. So azotemia is increase in blood urea nitrogen and creatinine, which is a marker for the kidneys' health. Like if kidney is functioning normally, there doesn't have to be increase in blood urea nitrogen and creatinine. And azotemia is increase in BUN and blood creatinine. So there is a uremia as well. Uremia is when azotemia is presented with symptoms, and those symptoms are pericarditis, gastroenteritis, and peripheral neuropathy. Other manifestations include urinary tract infections. For example, if we have UTIs or if we have any kind of bacterial infection that causes UTI, we have pyuria, which is pus in the urine, and microscopic hematuria, which is not seen with the eye. And for acute and chronic renal failure, we have azotemia and uremia, and both end either oliguria or anuria. So consequently, less urine, oliguria, and anuria when there's complete absence of urine. Okay, now the most important part is part with the glomerulonephritis. There are many types of glomerulonephritis. Most of them are characterized with the hypersensitivity reaction. We have two types of hypersensitivity reaction, and there's hypersensitivity type 2 and 3. The member which is involved in type 2 hypersensitivity reaction. This is antibody mediated. Is the example is a good posture syndrome. Specifically for kidney, a good posture syndrome with type 2 hypersensitivity is also called anti-basement membrane antibody disease. Now, important thing here is that we have antibodies against basement membrane, and if we apply immunofluorescent antibodies on top of those autoantibodies of the basement membrane, in the microscope we can see a linear deposition of antibodies. So it's going to be like this. It's going to be linear. It's not going to be like interrupted or anything. This is for a pathological point of view interesting, but in diagnostic it's not usually used. So the only linear deposition of antibodies are in type 2 hypersensitivity reaction, which is a good posture syndrome. Okay, now the second type of hypersensitivity, which includes 5 disorders of kidney, is immune complex mediated, as it's type 3 hypersensitivity. So according to the immune complex deposition, we have 3 types of diseases characterized with the subendothelial IC deposition. Subendothelial means that immune complexes are deposited below the endothelium of the blood vessel. Examples are lupus nephritis and membranoproliferative glomerulonephritis, right? And you can see here, this is the fluorescent antibody. So important thing to remember here is that the immune complexes are deposited below the endothelium. So subendothelial immune complex deposition, lupus nephritis, and membranoproliferative glomerulonephritis. So the second type is subepithelial immune complex deposition. So epithelium here is a basement membrane. So below the basement membrane, there's a deposition of immune complexes. Diseases include membranous glomerulonephritis and post-streptococcal glomerulonephritis. Now, how I remembered this two is looking here, we have two diseases here. Like here we have a membranous here, membrane, and we have membrane here as well. So two membranes. Membranoproliferative glomerulonephritis, this is much longer name. So I somehow remembered it's for the first type, which is subendothelial. So first membrane, which is a long name, is for subendothelial. And the second one, which is membranous glomerulonephritis or membranous glomerulosclerosis, is for the second type of IC deposition. In this case, is subepithelial. So those two membranous diseases, those two, are specifically kidney diseases. But we also have diseases that do not primarily affect kidneys. They secondarily affect kidneys, right? First is systemic lupus erythematosus, which can cause lupus nephritis. And the second one is post-streptococcal glomerulonephritis. This is a after exposure to Streptococcus pyogenes. If there's a pharyngitis or skin rash associated with this bacterium, after a few weeks, like 2 weeks, there can be a manifestation with the kidney injury, manifested with the subepithelial immune complex deposition. So that was two types that I talked about, and now we have a third type, and the only disease here is IgA nephropathy. This is mesangial immune complex deposition. So mesangial cell is a resident macrophage, you can see here, which is located in the center of glomeruli. And in this case, we have immune complex deposited on the mesangium, right? This is IgA nephropathy. So that's all. And important thing is here that all of those three types of immune complex depositions are characterized if we add immunofluorescence antibodies to the immune complexes, like here, here, and here. It's going to give us an image on microscope as the granular deposition of immune complexes. So it's like interrupted, it's not like linear, right? It's like this. Okay. Now I'm going to talk about the glomerular diseases one by one, starting with the first disease, which is a minimal change disease. This is the most common cause of nephrotic syndrome in children. So first three disorders, this, and this, are only symptomatic with the nephrotic syndrome, right? There's no blood in urine. So minimal change disease is usually for children up to 7 years of age. It's usually idiopathic, or it follows respiratory infection. It can be secondary after respiratory infections. And important for the mechanism is that there's a podocyte injury by the lymphocyte, which is mediated by cytokines. So morphology is effacement of podocytes. We have podocytes here. They're usually like this, and effacement means that they're getting thinner, right? As you can see here, this is the normal podocyte, and it got so thin, so it's effaced. So this is the morphology. Now, on light microscope, there's no change, so the name itself, minimal change disease, can predict to that. And the symptoms are only nephrotic syndrome. So there's a proteinuria, there's hypoalbuminemia, there's a hyperlipidemia, and hyperlipiduria. And the fourth one, which I didn't remember, is a generalized edema, right? So this is a very benign disease. So 95% have remission, and only 5% progress to the chronic renal failure. Now, the second glomerular disease is focal segmental glomerulosclerosis. So some pathologists like to consider this focal segmental glomerulosclerosis is kind of the same as minimal change disease, but it occurs in adults, right? So this is one of the most common causes of nephrotic syndrome in adults. The second one that is also very common is membranous glomerulonephritis. So those two, 1 and 2, are two most common causes of nephrotic syndromes in adults. So for this focal segmental glomerulosclerosis has also two types of progression. The most common is idiopathic, which is without known etiology, but secondarily it can also be associated with people with HIV infection, heroin abusers, or it can progress secondarily after IgA nephropathy, right? Now, there is a mechanism, is the same as with the minimal change disease. There's a the injury of the podocytes with the injury of podocytes by lymphocytes, and also deposition of proteins. And due to protein deposition, there's hyalinosis, which is thickening of the sclerosis of the structures. So the same morphology, this is effacement of podocytes. Here as well, podocytes have to be this large, but now they're thin. This is called effacement. And in light microscope, there is a visible change. So there's partial damage to the glomeruli. Not all glomeruli are affected. Some glomeruli are damaged, and there's sclerosis due to high amount of protein, right? Hyalinosis. And plus we have foamy macrophages here. Symptom is the same. It's only nephrotic syndrome, so nephritic syndrome is not present here. Now, that's another very common cause of nephrotic syndrome in adults. So in these three disorders, 1, 2, 3, they're only nephrotic syndromes. So nephritic syndrome is not present in either of those. Okay. So membranous glomerulonephritis is again one of the most causes of nephrotic syndrome in adults, associated with chronic hepatitis B, syphilis, systemic lupus erythematosus, and important thing as well is malignancy. Now, in the same way, it has a primary cause, which is idiopathic membranous glomerulonephritis, but secondarily, it can be associated with those disorders as well. And malignancy is an interesting thing to remember, because if the patient comes with the colon or lung cancer and he has a glomerulonephritis, it's most likely that the patient is experiencing membranous glomerulonephritis. So here as well, apart from HIV, drug abusers, and IgA nephropathy, obesity is also a predisposition to the focal segmental glomerulosclerosis. So obesity is also an interesting player here. Okay, it doesn't look very nice, but just write it here. Okay, so the secondary causes include hepatitis B, syphilis, systemic lupus, malignancy. Mechanism is deposition of subepithelial IC. So here comes type 3 hypersensitivity. Before, those two were associated with the podocyte damage, right? They're podocyte damage by the lymphocytes, but here we now have hypersensitivity reaction, which is type 3. This is subepithelial immune complex deposition below the basement membrane. In morphology, in an electron microscope, we can see deposition of subepithelial immune complexes. Though those are characterized with the spike and dome complexes. This is important to remember. And as well as the preceding two disorders, there is an effacement of podocytes here as well. So here podocytes look normal, but they're usually thin. In light microscope, thickening of basement membrane involving glomerulus diffusely. So the name of the disorder here is membranous glomerulonephritis. It's also called membranous glomerulosclerosis. So it can be logical that there's going to be thickening and sclerosis of the glomerulus as well. Symptom is only nephrotic syndrome. So there's no blood in the urine. It includes those 4 symptoms which are characteristic for the nephrotic syndrome. Now, this is, we go to the membranoproliferative glomerulonephritis. In this case, it mostly affects adults. The only case here is idiopathic, and mechanism is here deposition of subendothelial, so below the endothelium of the blood vessel. Again, type 3 hypersensitivity. Now, morphology here, there's deposition of the subendothelial immune complexes. An important thing here is there's a splitting of basement membrane as well. So basement membrane is usually like this, but in membranoproliferative glomerulonephritis we have splitting, like they're split in two. In light microscope, we see proliferation of mesangial cells and recruitment of white blood cells. You can see mesangial cells are here, and usually not that much in a regular kidney. And the interesting fact here is that it's either presented with the nephritic syndrome, with the blood in the urine, hypertension, and etc., or nephrotic syndrome, with the proteinuria. Okay, now the other nephropathies are IgA nephropathy. This, as well as the minimal change disease, follows respiratory tract infections. Here as well, there's a GI infections as well after 1 or 2 days. There's the deposition of immunoglobulin A's, which lead to inflammation. In morphology, an electron microscope, we can see mesangial deposition of immune complexes, as we remember from here. There's mesangial IC deposition in IgA nephropathy, as you can see the same here. In light microscope, there's an inflammation of glomeruli and proliferation of mesangial cells, and symptom is nephritic syndrome. And most undergo remission. It's not as severe as other disorders, so important thing to remember is it is characterized with the nephritic syndrome. So there's blood in urine. Okay, the remaining. Okay, this is the same here. We've already done that. It's aka IgA nephropathy is a Berger disease, and in case of C3 nephropathy, it's not as important as other nephropathies. This is also called a membranoproliferative glomerulonephritis type 2. This is type 1. Type 1. This is MPGN type 2. And it's also called dense deposit disease. I'm not going to write it. It's super giant font. So it's also called dense deposit disease. It is much less common. It mostly affects adults. It's idiopathic. And the mechanism is deposition of C3 nephrotic factor. There's a deposition of C3 in the electron microscope. In light microscope, we can see proliferation of mesangial cells and resplitting of basement membrane, and it progresses symptomatically either with the nephritic or nephrotic syndrome. And the last glomerulonephritis is going to be post-streptococcal glomerulonephritis, which is after the infection with the strep pyogenes, usually with associated with skin. It's mostly affects children, but it can also affect adults as well. It is associated with either with skin, most commonly with skin, or pharyngeal infections caused by Streptococcus pyogenes, and it develops usually 2 to 3 weeks after infection, right? In mechanism, we have deposition of subepithelial IC, immune complex deposition, as we remember from here. We have post-streptococcal glomerulonephritis below the basement membrane. Epithelium. This is epithelium, so below that. Okay, we're done here. And we have multiple leukocytes in the glomeruli. And deposition of subepithelial immune complexes are called as humps. We have to remember, such as spikes and domes. For other, in case of the membranous glomerulonephritis, we have characteristic cells, which is spikes and dome complexes. Here we have humps. Symptom is nephritic syndrome, right? It has blood in urine. 90% go to remission, but unfortunately 10% can progress to chronic renal failure. Okay. Now we're going to discuss tubular interstitial nephritis. So in tubular interstitial nephritis, we have 2 types of condition. This is when there's a damage to tubules, and there's either most commonly pyelonephritis, which is a bacterial infection causing injury to kidney, especially tubules of the kidney, or there can be drug-induced nephritis. This is allergic reaction to the drugs. So first, let's discuss the drug-induced nephritis. The drugs that can cause this allergic reaction include NSAIDs, iodine contrast, penicillin, and sulfa drugs, which have sulfa moiety in their structure. Those are sulfonamides, loop diuretics, and thiazides. And symptoms include the typical allergic symptoms such as fever, rash, and hypertension. And in the renal case of kidney, there's renal abnormalities such as eosinophils and eosinophil casts in the urine, and also proteinuria due to the kidney damage. And complication, this can lead to chronic renal failure. So it's not usually after several intakes of those drugs. If the patient continues to consequently take those drugs, regardless of having this allergic reaction, it can progress to chronic renal failure. But it's not going to happen via one administration of the drug, single administration. So important thing here is eosinophilic casts. Here, eosinophils and eosinophil casts in the urine, which means that due to allergic reaction, there's a high concentration eosinophils that are going to get filtered in the urine. So casts are usually accumulations of specific material. In this case, we have eosinophils. There are different types of casts that can indicate certain problem. For example, in acute renal failure, we have granular casts. So this is accumulation of epithelial cells, which are due to the necrosis, ischemic necrosis, usually of the tubular cells, right? We have tubular cells, those are very prone to necrosis. So if there's any kind of problem causing ischemia to the tubular cells, which is in case of acute renal failure, it can lead to of those epithelial cells, and it will create granular casts, which are epithelial casts in the urine. So in chronic renal failure, we have vaxicasts. In pyelonephritis and allergic nephritis, we have white blood cell casts, so it's logical. There's white blood cells in allergic and also in bacterial infection. In case of nephrotic syndrome, we have fatty casts, as there's a lot of lipoprotein which is getting filtered in the urine. So we're going to have an accumulation of lipoproteins in the urine. Those are called fatty casts. And hyaline casts, which are accumulations of proteins. You remember there's more than 3.5 grams of protein in the urine in 24-hour sample. So in nephrotic syndrome, characteristic casts are those. In nephritic syndrome, on the other hand, we have red blood cell casts. So it's the accumulation of red blood cells, which can be seen in nephritic syndrome. Okay. Now let's go to the pyelonephritis. We have acute pyelonephritis and chronic one. Acute pyelonephritis is usually caused by the bacterium which colonizes the kidney via the ascending route. This is usually from the urethra, and mostly associated with catheterization, which is not done in a sterile way, or any other manipulation that is, for example, there's a obstruction and the person's bladder is full, and there has to be some kind of percutaneous manipulation necessary to empty the bladder. So in this case, the most common cause is like in 90% of cases, there's an ascending route for infection, which causes acute pyelonephritis. Etiologies include E. coli, Proteus, and Klebsiella. In case of the hematogenous infection, which is secondarily to, for example, bacterial endocarditis, or it can be osteomyelitis, usually caused by Staphylococcus aureus, there can be a seeding of bacterium via the bloodstream into the kidney, which can cause the acute pyelonephritis, but it's much less common. So morphology includes pus in the renal parenchyma, and there will be a lot of polymorphonuclear neutrophils and multiple microabscesses in the kidney, and the tubules specifically. So symptoms include regular bacterial infection symptoms, which is a high fever, shaking, chills, sweating, flank pain due to the kidney injury, flank tenderness on percussion. There can be also tenderness of the abdomen. It includes nausea and vomiting, dysuria, which is a painful urination, urgency, which is a frequent desire of urination, even though the person might not urinate a lot. It can be a very small amount of urine per urination. And there's a frequency of urination, right? There's a lot of urine in a very short time. In urinalysis, the most distinctive characteristic is pyuria, which is pus in the urine, increased white blood cells, and consequently accumulations of white blood cells, which are white blood cell casts, like this. Turbo-blue tetrazolium test, which is elevated leukocyte esterase. There can be few RBCs, and those microscopic hematuria, and complications are papillary necrosis, which is serious complication, and renal abscess. Okay, now let's go. And the second is a chronic pyelonephritis. Okay. Now in this case, there's acute kidney injury, acute kidney failure. We have factors that can provoke and cause the acute kidney injury. Those include blood loss, dehydration, diabetes insipidus, and diabetes mellitus. So those that can cause hypovolemic shock, consequently a very drastic decrease in arterial blood pressure. It also can be caused other kinds of shocks, such as cardiogenic shock or septic and anaphylactic shock. So any kind of condition that decreases the blood pressure severely, mostly by any kind of shock, basically. So decreased arterial blood pressure is going to decrease the renal blood flow. There can also be renal artery thrombosis, or it can be stenosis as well, which will consequently decrease renal blood flow. This will cause tubular ischemia, and the mechanism for this is, like you see, there's an afferent arterial or artery, and there's like a kidney, and there's efferent artery, right? So if there's a stenosis, thrombosis, or just simply hypovolemia, a little amount of blood is going to get filtered in the glomerulus, right? So it's going to trigger a renin-angiotensin system, which is going to constrict efferent arteriole farther to try to increase the GFR. Because if there's a little filtration, there's decreased GFR. So kidney is trying to compensate to increase the GFR as it can. So if there's a hypovolemia, little blood is getting filtered, little blood goes to the efferent arteriole, which is going down to the kidney tubules, and those are characteristic with the vasa recta, which is going to supply kidney tubules, right? So if there's constriction of the efferent arteriole, the less blood is going to get into this arteriole, and less blood is going to be supplying vasa recta. So tubules are going to get little oxygen and nutrients, which is going to cause ischemia and necrosis, right? So we have, due to tubular ischemia, we have acute tubular necrosis. This also can be caused with toxic agents such as iodine contrast, myoglobin, amphotericin B, aminoglycosides, and cisplatin as well, right? So desquamation of tubular cells, cham obscura, occlusion of the tubules, so those epithelial cells that are going to desquamate can get stuck in the tubules, and it will consequently decrease the urine flow. It can be manifested either with oliguria or anuria, and it's going to cause azotemia or uremia, right? And/or. So if there's an obstruction of the tubules and the urine is not, so basically if there's decreased filtration, and filtration is going to be decreased due to less blood supply, and also with the occlusion of the tubules, so urine, it will not be able to pass in the tubules, right? Pressure is going to increase, net filtration from the blood vessel to the glomerulus is going to decrease even farther because of the increased pressure in the tubules. This is going to create a problem because blood urea nitrogen and creatinine is not going to get filtered. This is going to increase those levels, and it will cause azotemia. And if it's characterized with symptoms such as gastroenteritis, if I'm correct, peripheral neuropathy, or any kind of problem, it is going to be characteristic for uremia. So symptomatic azotemia, aka uremia. So all of this is going to cause acute renal failure. If the problem is fixed quickly, tubular cells have a good regenerative capacity, so they can reverse the injury. But if not, probably it can progress to chronic renal failure. Okay, now this renal vascular diseases. This is nephrosclerosis. There are two types. There's a benign nephrosclerosis, which is associated with the long-standing hypertension. So there's a sclerosis of the glomerulus. Usually, this is as it's connected with hypertension. Diabetes is a very common cause as well. So chronic hypertension causes chronic injury of renal blood vessels. There's accumulation of protein in vascular wall. So there's a hyalinization of the vessels. So it's going to decrease the lumen. If the lumen was like this, it's going to decrease the lumen even farther because there's accumulation of proteins here, right? So it's going to create hyaline arteriosclerosis. So this is called benign nephrosclerosis, hyaline arteriosclerosis, caused by long-standing hypertension, regular hypertension. The second cause is malignant nephrosclerosis. This is associated with malignant hypertension. If I'm correct, it's like 120 systolic, 220 diastolic. This is characteristic for malignant hypertension. For malignant hypertension, there is recurrent injury to the renal blood vessels, and there's fibrinoid necrosis with the hyperplasia of the vascular smooth muscle, and this is characterized with the onion skin sclerosis. This is called hyperplastic arteriosclerosis. So malignant hypertension is associated with the hyperplastic. The regular hypertension is associated with hyaline arteriosclerosis. So both of those arteriosclerosis are going to cause fibrosis and obliteration of glomerular capillaries and glomeruli itself, and it's going to most certainly cause a chronic renal failure. Right? Fibrinoid necrosis around blood vessel, onion skin appearance. Now we have polycystic kidney diseases here. We have autosomal dominant kidney disease, which is the most common and most important. This is second most common autosomal dominant disease after familial hypercholesterolemia in all of the autosomal dominant disorders. There's most common is the gene mutation in the PKD1 gene in 90%, more than 90% cases, and the second cause is mutation in PKD gene 2. Now PKD gene 1 is going to express polycystin 1, which is a mechanoreceptor, and PK2 gene is going to be characterized with the expression of the polycystin 2, which is regulator of the calcium channel. The morphology is characteristic with the multiple renal cysts bilaterally, so both kidneys are involved, and microscopically cysts are lined by tubular epithelium, and they're usually filled with fluid, if I remember correctly. Symptoms appear 40 to 50 years of age, even though it can be, it's from the birth, it's present. Symptoms appear only after 40 to 50 years of age. The complications are recurrent pyelonephritis, fever, flank pain, chills, pyuria, dysuria, hemorrhages with the cysts, flank pain, hematuria if the cyst ruptures. There's nephrolithiasis, which is stones in the ureters. And complications are hypertension, chronic liver failure. Coincidence, there is the same mechanism involved in Wilms, the aneurysm of circle of Willis, which can cause subarachnoid hemorrhage, and it can also be manifested with the hepatic cysts. So you see polycystin 1, polycystin 2. Usually polycystin 1 is one with the defective, right? Defective polycystin 1 causes decreased tubular cell ciliary motion, so cilias are defective, increased tubular cell secretion, and abnormal cells and cell matrix interaction. So if the ciliary motion is decreased, secretion is not happening as it has to, and I believe absorption is defective as well. So this will cause the stasis of urine and the tubules. So if the urine is not flowing as it should be, there's a high risk of getting infections, ascending infection. It will cause increased intraluminal pressure of the tubules, enlargement of the tubules, and formation of renal stones. So intraluminal pressure will decrease the GFR, filtration will be decreased because of this. Now we have autosomal recessive polycystic kidney disease, which is much rarer. In this case, the problem is with the PKHD1 gene, which expresses the fibrocystine protein, fibrocystine 1, if I believe correctly. This is regulator of the calcium channel, as polycystin 2 was. Symptoms appear early at the time of birth. There's azotemia, anemia, hypertension, and unfortunately this is most likely going to be fatal a few months after birth. There's end-stage renal failure and bilateral cysts and liver cysts leading to cirrhosis and death, right? Okay, and the last, not the last topic, but not much is left. Now, thrombotic microangiopathies are associated with the hemolytic anemia. First, and the most common, is hemolytic uremic syndrome, which is associated with the Shiga toxin. It can be by the E. coli. I believe it's not enterohemorrhagic, if I believe correctly, but I'm not sure. It's E. coli 0157, which has a Shiga-like toxin, and Shigella dysentery, which has the Shiga toxin as well. So this is the typical hemolytic uremic syndrome caused by those bacteria. There's also a atypical, which is associated with the complement overactivation. This is going to be connected with the not classical, not leptin, alternative pathway of the complement activation. Or it can be caused by hereditary disorders as well. So symptoms include thrombocytopenia, and this is petachia and purpura, hemolytic anemia, which is going to be manifested with pale skin and fatigue, and glomerulonephritis with the hematuria and nephritic syndrome. So Shiga toxin and complement is going to cause endothelial damage. This is going to lead to expression of adhesion molecules and release of thrombogenic factors. I believe it's going to going to decrease the release of endothelin, and it's going to increase the release of endothelin and decrease the release of nitric oxide, which is going to further constrict the blood vessel. These thrombogenic factors are going to trigger coagulation cascade, and this will cause formation of multiple thrombi, and hemolytic uremic syndrome will ensue. In the second case, there's a TTP, thrombotic thrombocytopenic purpura. In this case, the most common case is hereditary, which is mutation in ADAMTS 13 gene, which is a gene that codes for von Willebrand factor. It's a gene that codes for the protein that cleaves von Willebrand's factor to its lethal functional proteins, right? There's two types, acquired and hereditary. Acquired is antibodies are against those ADAMTS 13 protein, which is going to destroy those. Symptoms include thrombocytopenia, characterized with petechia and purpura, hemolytic anemia, pale skin and fatigue, glomerulonephritis with the hematuria and nephritic syndrome, and fever. Neurologic abnormalities are seizures, decreased consciousness. This is neurologic abnormalities are characteristic only for TTP. That can be the thing that we can differentiate with. Right. Okay. Now let's go to the hydronephrosis. Hydronephrosis is when there's any kind of obstruction that causes the buildup of urine in the ureter in the kidneys. Either it can be unilateral or bilateral. So the most common causes, congenital ones, are vesicoureteral reflux disease, when ureters are not connected properly to the bladder. This can cause the reflux of the urine back to the ureters, causing hydronephrosis, or it can also cause pyelonephritis, if I'm correctly aware. There's posterior urethral walls, so usually walls that are not supposed to be present there, and duplication of ureter. So ureter, if there's too little ureters, which can cause the buildup of urine in the bladder. Acquired include uretiliasis. Those are stones of the ureters. And there's retroperitoneal tumors that can push the ureters and cause the obstruction. There's benign prostatic hyperplasia or prostate cancer, also causing obstruction, and neurologic bladder, which is characteristic for diabetic patients, and pregnancy. Anything that can obstruct the ureters, right? So this will definitely probably will lead to chronic renal failure, and as I said, it can be bilateral or unilateral. If there's if there's a unilateral, it's usually asymptomatic, and it's more problematic because one kidney is probably going to progress to chronic renal failure without being noticed. But if it's bilateral, both kidneys are non-functional, so if we fix it, the irreversible kidney damage will be restored, right? It will not lead to irreversible kidney damage. So that's the last part. Okay, renal stones, right? We have symptoms of renal stones include acute or severe flank pain, which moves toward the lower abdomen and finally localizes to groin. There's dysuria, painful urination. There's either hematuria, it can be present or not. We have nausea, vomiting, and flank tenderness on percussion. So the most common types of stones are calcium oxalate or calcium phosphate stones. 80% of them are those. Most of them are idiopathic. Less common are hypercalcemia due to hyperthyroidism, metastatic diseases, vitamin D toxicity, and drugs that include calcium-containing drugs such as loop diuretics, radioquinone X-ray or CT. So the second most common stones are struvate stones, which are magnesium bicarbonate sulfate stones. Sulfate stones. Causes are 10% associated with infection of urinary tract by Proteus, which those are the bacteria that has a urea splitting capacity. This is urease positive bacteria that can cause struvate stones, and it causes the Stracron calculi. Right. This third most common is urate stone, which is a uric acid stone, approximately 8%. If there's an increased uric acid production, Lesch-Nyhan syndrome, Kymmer-Lysis syndrome, increased uric acid excretion that can be caused by probenecid and low pH. And the last one is cystine stones. This is with genetic diseases when there's the problem with the reabsorption of the cysteine, and it's less than 2% of cases. Right, and the last one is a renal cell carcinoma. The most common is a clear cell carcinoma, as this is associated with polycystic kidney diseases. The risk factor can be smoking and diabetes as well. Symptoms include painless gross hematuria in the absence, nephritic syndrome, so it's going to be visible hematuria, mass in the flank region. There can be pain or discomfort in the flank region, and it can also be characterized with paraneoplastic syndrome, which include the production of a lot of erythropoietin, which will cause the increased synthesis of RBCs, leading to polycythemia. Also, it can cause a Cushing-like syndrome with the increased synthesis of steroids. And morphology is cells, glycogen-laden clear cells that are characterized with the very pale white cytoplasm. So I guess that was all. Bye.